We are going to move to our next session, the next portion of this session, which is a transition to a transition topic, and that is the transition of care after hospitalization for CCHD. We're very honored. We will be bringing back all of our panelists, all of our speakers at the end of this, by the way. But we're very honored to have Dr. Ginny Abarbanel, who is Chief of Pediatric Cardiology and Professor in the Department of Pediatrics, Division of Pediatric Cardiology at UT Southwest, at UT Health Science Center, San Antonio. Prior to joining UT San Antonio, Dr. Abarbanelli practiced pediatric cardiology in numerous locales, such as Indianapolis, Atlanta, and St. Louis. She's been involved in public health research with the CDC and currently holds the office of treasurer with the Cardiac Neurodevelopmental Outcomes Collaborative. Her interests include quality improvement, cardio neurodevelopment, and fetal cardiology. On a more personal note, actually, Dr. Abarbanel and her husband, Dr. Aaron Abarbanel, are a team. Her husband is chief of pediatric cardiothoracic surgery at UT San Antonio's Health Science Center. Our second speaker, and this will be an interesting question and answer session, is Alexandra Watson Hassan. She is the Dallas chapter lead for the Mended Little Hearts organization and mother to a 9-month-old son, Henry. Henry was born with multiple congenital heart defects, transposition of the great arteries, a large VSD, and an ASD. Previously, Alexandra worked as a marketing professional and has been able to apply that experience to helping raise awareness of congenital heart diseases and support for heart warrior families through Mended Little Hearts. And she lives in Dallas with her husband and son. And Heather DiGiovanni is a pediatric pulmonary physician assistant for Texas Pediatric Specialists and Family Sleep Center. In that role, Mrs. DiGiovanni serves as an inpatient practitioner, providing care to acutely ill children and their families. She has a special interest in pulmonology and cardiac care, and is deeply committed to patient education and believes in empowering children and families in taking action to improve health and daily quality of life. And she lives in San Antonio, Texas, with her husband, her 2 daughters, and 2 Pomeranians, very important. She's the mother of a congenital heart disease warrior who is now 19 years old. Her daughter was born with tetralogy of Fallot and has endured 2 open heart surgeries, cardiac catheterizations, and numerous non-invasive procedures. So our 3 panelists will now begin a nice discussion, and I think in a question and answer format between them, involving the transition of care after hospitalization for CCHD. Welcome.
Thank you so much for having us. And, it is Friday afternoon at 4:36. So I hope you all will enjoy this discussion. I hope it is engaging. And we have no slides, so no falling asleep because we don't have any slides. What I was asked to do this portion of this talk was the transition of care after hospitalization from CHD. And I thought, I really can't tell this story. I need our parents to tell the story. And so I reached out to some different folks from Mended Little Hearts to find an advocate for Mended Little Hearts. And then I ran into Heather through kind of a circuitous route here in San Antonio and learned her story. So I think that they both have amazing things to chat about. And the only other thing I'm going to add before we start talking is the prenatal screening, I think, is just as important as the postnatal oxygen screening. I will say in the state of Texas, we're about 25% prenatal detection rate, and the postnatal screening with oxygen saturations is also just as important, and trying to figure out ways to track that is very important. So I was just going to start our discussion by having each one of you, Alex and Heather, kind of give us 5 minutes each about your story. And what is your story as being a mom of a child born with heart disease?
Sure. I can go first. I'm Alex. My son Henry is 9 months old. So he was born in April. We found out about his heart condition at about 34 weeks pregnant. And to Dr. Barbanel's point, it was actually just by luck. It practice at my OB-GYN's office to do a 34-week ultrasound just to check the size and make sure that they're tracking with the projected due date. And at the 20-week scan, everything had looked good. We had done all the genetic testing and screening. So at that point, we were packing our hospital bag, thinking we were good to go. We've, checked all the boxes. And at that 34-week scan, that was really just for the size. They detected the TGA, actually. The very next day, we were sent to a high-risk OB-GYN who confirmed the diagnosis. He also had a large VSD. And just due to some insurance challenges, we actually had to transfer our care to Houston. So at about 35, 36 weeks, we went down to Houston, had a full day of meetings with the doctors there, had a new OB-GYN, new cardiologist, all of that. So we kind of just picked up and went to Houston for the last month of pregnancy. I was induced at 39 weeks. And then luckily, because of how Texas Children's is set up with, you're able to deliver at the same hospital, we were able to be with Henry the entire time. So after delivery was normal, I was able to deliver with, no complications at that point. When he was born, his oxygen looked decent. It didn't look as bad as they were expecting. And so he was taken to the CICU. My husband went with him, and then just kind of the next few days, he started to kind of deteriorate as we were waiting for news about scheduling the surgery and things like that. So at the end of the day, what he was diagnosed with was TGA, a very large VSD, and an ASD. A few days after he was born, they had to do the septostomy, where they opened the hole again to allow for more oxygen mixing. And then on day 9, he finally had his open heart surgery. And then from there, we were in the hospital about a month with a few complications. He developed chylothorax. He was having just a really hard time feeding after having the NG tube put in. Administering medications were a challenge, things like that. So despite all of that, we got to a point where everything was looking good. The only last hurdle was really his feeding. So my husband is a physician, so we felt comfortable actually going home on an NG tube. Looking back, I do not recommend that to other mothers. It was probably one of the most stressful things we've ever done. But we decided that at that point, I think for all of our healing, we just needed to get home and kind of start our life as a family of 3. So at a month old, we left the hospital, and Henry had not gained a single pound. He was still 7 pounds, same as he was born. And so the feeding was a huge stress. And I know we'll kind of transition to that part on the next section. But yes, just I think as the early detection really allowed us to get him the care he needed and allowed us to make the planning, do all the planning that we needed. So I think that's just incredibly important for these kids and their outcome.
I've had some connection issues, and I want to know, is that on everyone's end or is it just on mine?
I've had a few connection issues, but I can see and hear you just fine.
Okay, so thank you for having me. My name is Heather DiGiovanni, and I think I have a different, a unique story in that I got pregnant when I was 17 years old, and Coral is my 19-year-old, and she was born with a variant of tetralogy of Fallot, but we didn't actually find out until Coral was born that she had a heart defect, and that was every bit of opposite of what I had preconceived or drummed up her to be. When you're 17, you just turned 18, and you think you're going to have a normal, healthy baby. My 20-week scan was completely normal. I was told that she had no issues, and so it was a real surprise to learn of Coral's heart defect soon after she was born. And so you grow up really fast, and I had no dealings with medicine at that point. I had been myself otherwise healthy, and the baby of 5 siblings that had been healthy. So you learn about what a cardiologist is, what a neonatologist is, what an echo tech is. You learn all of this in a short amount of time. So I felt like I was drinking out of a fire hose, trying to just process everything. And so Coral, because she was born with a variant of tetralogy of Fallot, she didn't have intervention right away. So I got to take her home. So I didn't have an upfront hospital stay as some do with her defect. She was a bit blue. She had kind of a somewhat cyanotic because she had this bidirectional flow. So she did live in the 80s. She wasn't that pink, pink colored baby that I was taking home. So I had a lot of challenges early on because I did take her home. I didn't feel like I was quite prepared or as educated I was like to be. I was so terrified to let her cry because she would get really dusky and really purple. And so for me, and we didn't go home on any sort of pulse oximeter to monitor her SATs. And so for me, you spend a lot of time, a lot of sleepless nights making sure she's doing okay. And we underwent her first cardiac cath. So Coral was born in December. We underwent her first cardiac catheterization in April. And then she got RSV. And again, that was something I hadn't really been prepared for. And that hospital stay really delayed things for her first complete repair. So since this time, and Coral underwent her complete repair at 8 months of age. And I also don't recommend a feeding tube because that was a struggle in itself. After Coral got RSV, we really struggled with just good stamina to complete feeds. And so, that brings on a set of challenges. And for an 18-year-old, I don't recommend. But after her complete repair, we did good. She did really, really well. We had what I would think was a normal hospital stay of something like 10 to 12 days. And we went on with our lives. We treated Coral like she was a normal child. I never wanted to withhold her from anything. And I never wanted her to feel different. That was kind of my biggest thing. And unique to us is Coral has an aunt that has a variant of tetralogy of Fallot as well. And so what I learned from how they treated her aunt to how I was treating Coral was they really secluded her aunt. They really prevented her from living life when she was growing up. Now, she's had 6 open heart surgeries, her aunt, to date. So I think I have to point that out. So they were really terrified. And that was back in she was born in the 70s. So things have really changed by this point. But my overall experience of just how sheltered they treated Coral's aunt, I didn't want that for our daughter. And so it really wasn't until she needed her next open heart surgery at the age of 9 that we really had to start talking about her differences. And she was fully aware of, and to some degree, really excited to be admitted for open heart surgery and kind of go through that process because she was going to be in the hospital. And then she wasn't excited. Post-operatively, the chest tubes and all of that was not really exciting for her. And that's changed her perspective today. So she's 19, and we've been really fortunate to get this far. She's been in good health otherwise. And now it's me focusing the importance of transitioning to adult congenital and really getting her to own her disease process. So,
well, thank you both. I'm just making sure we stay on time because it is Friday afternoon, so it's 4:50. A couple of things, maybe we can combine these questions together in the last 10 minutes. One was maybe give one or two things about what it was like going home, and then what, looking back, do you wish you had known? So Alex, do you want to start?
Sure. I thought about this a lot coming in, just remembering what it was like coming home. And I think overall, just having been through such a traumatic experience at the beginning, and then a lot of times I realized, like, emotionally, I wasn't necessarily dealing with it at the time because you're just in survival mode. And so then having to come home and then realize everything that's just happened to you, plus in our case, coming home with the NG tube. I mean, our son was eating probably every 1.5 to 2.5 hours. So it required, cleaning the pump, the sterile water. I was also pumping, and it was just a never ending list of things that my husband and I had to do. And just to kind of lead into things I wish we would have known, I think we were definitely trained on how to do the NG feeds and how to make sure everything was clean and the process of that. I think what there wasn't much focus on was what is the end goal. So I don't think any mom wants their child long-term on any kind of feeding tube, unless they have to be for medical reasons. So that I understand, but I don't think we were ever really prepared or really knew how to get to that point where we could transition off of the NG tube. So in our case, just to make it quick, our son ended up pulling it out one night, and he was eating enough at that point that we decided to just let him kind of go for it and see how he did. And he did great, and he gained enough weight that we could continue testing that. But I think the NG tube also, what was frustrating for us is it just caused, vomiting and gagging and other things that essentially inhibit his want to eat or his motivation to eat. So it is, I know it's a balance, and I really don't know the right answer for that, but I think it's something just to consider as parents go home. How can we support that process? And then just very quickly, I just had two other things that I wish I would have known. One, I think this is great what we're doing here. I don't think there's enough awareness that CHDs are the #1 birth defect. I think we talk about Down syndrome and many other syndromes and conditions that are less common. I wasn't prepared at all to hear that my child had a heart condition. So I think just more conversations around that to educate expectant mothers, I think, would be great. And lastly, looking back, I think the biggest thing for us would have been support from a therapist or more mental health support, both in the hospital and after. We did seek that out, and we were not, COVID had a lot to do with that too, because I know organizations like Mended Little Hearts many times are in the hospital talking to patients in the rooms live and kind of providing some of that peer-to-peer support. I actually didn't know about Mended Little Hearts until after our hospital stay, but I think having those therapists that are specialized in parents that have gone through a trauma like this is very important, or just having someone to talk to that has been in your shoes. Because at the end of the day, you can join the Facebook group, but it's not the same as having somebody tell you their story, and really hearing somebody else's story. It gives you so much hope that nowadays, like, a heart condition is not a death sentence. Mm-hmm. And I think for many of us, when you hear that news, that's how you take it. And really, that's not reality anymore. In very rare cases, of course, it is. But for most of us, we're very lucky that science has come so far, and your child will be okay. And we've been one of the lucky ones. So thank you, Texas Children, for everybody on this call.
I think it's really hard. I mean, Coral is she'll be 20 this year. And so I feel like just overall, as the evolution of our knowledge grows, that the things that going home for me were missing, I think we hit now. We do talk about, what's appropriate or how long is appropriate to let your baby cry. And I think we do a really good job about talking about, daycare and being mindful of viral precautions and good hand hygiene. I think all the things that I was missing back then, I think we talk about now. So at least I know I do when I'm dealing with a pulmonary patient that's a mutual with cardiology. So I think for the things that I wish I knew, we're talking about now. So. I think there's some comments in the side over here that mention, was a G-tube discussed or offered? No, not for us. But there was also, there was an end game for us. It was just going to be a very temporary short few weeks to bridge until repair. So we didn't even talk about G-tube. In fact, I didn't even know what a G-tube was until I became educated in the world of medicine. So yeah, not on my end.
It wasn't for us either. Yeah.
Go ahead, Alice.
Oh, I was just going to say it's similar. I think the expectation was that, all babies after open heart surgery a lot of times have that trouble feeding, so that this would just be a temporary kind of bridge until he got there. And I think the medication is really the most challenging part in terms of giving a baby, 5 different medications a day. And that's kind of where the NC tube came in.
I just have a couple questions for you all. I know there's some more in the chat that we can get to in a little bit, but Alex, my question for you is, you're doing stuff with Mended Little Hearts, so I'm gonna ask you the question and Heather at the same time, so you can just go from one to the next. But can you talk a little bit about what Mended Little Hearts does? And then for you, Heather, I think the most interesting part of your journey is how you became a physician assistant after all of this. So we'll start with Alex, a little bit about Mended Little Hearts, and then Heather, if you could finish us up with your story and how you became a physician assistant.
Sure. So Mended Little Hearts really provides support for families who are in the hospital and both after their hospitalization. So families of children with congenital heart defects. When they're in the hospital, what we like to do is work with the social work team to deliver bravery bags. So they will have, a little heart bear or things for the kids, depending on the age. So if it's a newborn set, they might give them, clothing or a little lovey, something appropriate for that age group. If it's an older child, maybe an activity book. And just to let them know, this organization exists. You can reach out to them if you need a mom to talk to. We have moms on call all the time who have probably the same thing your child does. There's a huge network of moms. So they're available both on the phone, on social media, in person, however you would like to meet with them. And then after, we do have our different chapters in each city. So I think most of the major cities have one. Right now, because of COVID, we're a little bit, we're not doing as many events, but we're still very active on social. And we try to kind of create that community. So really just having someplace for moms and dads to go and talk to other parents that have been through something, even if it's a simple question like, have you ever been given this medication? It's really just meant to provide a peer network for them to feel, not isolated in this horrible situation that they're in. So we hope to, once COVID is over, to do more of those in-person events and provide more in-person support at the hospitals as well.
I can say that, my brief interaction with Mended Little Hearts around Coral's second open heart surgery, at this point I was working with a team already, and I thought it was really good. Coral was able to actually see other kids at these events that had heart disease. And, you spoke a little bit about the, mental health piece, or the just counseling overall for us as parents, but then for our children to actually process and own their disease. I thought it was the first time that I started to really realize the importance of letting Coral interact and see other kids like her. Because again, I think it was just me wanting to not label her, but not really truly helping her process, I think. And so Mended Little Hearts definitely did add that for us when she was going through it, just to see other. So it was nice too to interact with other moms. And it was not something I was even aware was in our community. So I look forward to, you know, post-COVID events. Okay, and so it was asked of me. So I have to say I had a very non-traditional upbringing. Short of being raised in the system, I'm very grateful for having grandparents that provided stability for me. But I come from a drug-addicted mom, and she was very absent. But my grandparents were there, and hence the reason why I was up to grown folk business when I shouldn't have been, and got pregnant at 17. So, but I was on track to graduate early, and I wanted to do something in the world of fashion design and merchandising. That's what I was set to do. Getting pregnant with Coral made me realize that I was going to need more family support. And maybe I didn't need to dream so big that I could stay local and enroll in our community college. And at that point, I still had no idea what direction I was going to go. But the more time I spent at the hospital, the more time I interacted with the team taking care of Coral, I realized maybe I could do something in medicine. And so I set out to be a respiratory therapist. And I did that for 4 years before I had the push of the pulmonologist I was working with say, I think you have more in you. You can go a little further. And so they gave me the confidence to apply to PA school. And around the time that I was finding out if I was being accepted, Coral was undergoing her second open heart surgery, and with the team, the same team that did it those 9 years ago or previously. And so I told the surgeon at the time that I was awaiting confirmation of getting into PA school, but if I did, would they be willing to allow me to use my elective to spend time with the team? And sure enough, I got accepted, and they made good on their end of letting me complete my clinical rotation with them. And at the end of it, I was offered a position. So short of me passing my boards, I had a job lined up. And so once I passed my boards, I came on board, and I worked in the world of congenital heart surgery for 3 years. And that's kind of my story of how I even got started with all this. It was through Coral and my experience working with a phenomenal team, somebody that helped really handhold me. And I wanted to just give back. So.
Thank you both. I think you both have an amazing story, and all of our parents have amazing stories. And I think these stories are important in understanding the importance of making sure that we diagnose congenital heart disease, also understanding the neurodevelopmental process related to congenital heart disease, and following the spectrum. There's a bunch of questions about adult congenital, which is a whole nother topic. With that, I'm going to turn it over to Dr. Wisely.
Thank you. That was a great session. Thank you, Alex, and thank you, Heather. Thank you, Dr. Barbanel. We're going to now, we have about 15 minutes for a question and answer session. We've had a number of questions, and we'll invite back all of our presenters. Dr. Martin, Dr. Gong, Dr. Guillory will join us again and on screen, so everybody will feel free to put their cameras on. The first question I've been given is guided kind of at Dr. Martin, and probably also I would say Dr. Gong, Dr. Guillory had brought up that we have proposed and are in the process of proposing to the statewide perinatal quality collaborative, TCHMB, a QI project on statewide on CCHD screening for our statewide collaborative. Could you give us any suggestions for this project on ways we could succeed early and ways that we can get everyone to participate?
Who wants to talk? I guess I could start. Oh, do you want to go?
Go ahead, Dr. Gong, and then we'll follow with Dr. Martin. Sure.
So actually, I think it's quite feasible to do because, and that the RAC is great because all the delivering hospitals are members of a RAC, and there's 22 regions in Texas, so 200 and something delivery hospitals, and that's kind of where we don't know if the word got out to all the places that this should be a screen that they do. So one, we could find out if they have a program in each of these hospitals. So if they sign up, they'll let you know that they have a program, and then kind of what their process is and how they can do quality improvement in training their staff. So those are very important things to make sure that babies are screened and that parents are also educated. The screen is great, but it doesn't pick up everything. And so education, we feel like the most important thing is telling parents that their child may have something. And if their child is not eating well, if something changes early, that they get back into care. So the process, I think, can be easily done. And I just hope that all the hospitals would be willing, because this is such an important thing that we can do. Remember that heart disease is not that we're going to pick up all heart diseases, but it is the #1 cause of death in the first year, barring prematurity.
Dr. Martin, your comments?
Can you hear?
Dr. Martin, are you able to? Oh, there you go. Yeah, your comments, please.
Yeah, sure. I think even in states that have mandatory screening, I think one of the keys is not having mandatory reporting. And a lot of states decided that they would write their laws in a way that they would get through legislation. It's the same things, it's the same compromises in the protocol that we made early on to not have a lot of false positives. So I think one thing it may be at some point is going back and thinking about rewriting the law in Texas that says mandatory reporting. That's the only way for the Department of Health to know, by having each hospital send a monthly or quarterly report saying we had 10,000 births, we had, 9,000 babies screened, and the other 1,000 were premature or, and were excluded. That's really, I think, one thing. I think the education piece is huge, and engaging the parents is huge to put pressures on the hospitals, because I think some hospitals aren't doing it. And I'm going to raise it. You said it early on. I think Dr. Guillory and maybe Dr. Guy, it's an issue, I think, of disparity. What I think people find is that it's areas of a region that have lower socioeconomic status, that there's less resources at those hospitals, and those are the babies that need the most coverage, because they might be going home into a much more vulnerable situation.
Thank you. Dr. Guillory, you're on mute.
Just to add on to the comments, #1, the Texas Collaborative, one of the things that we have initiated is that every quality improvement project that we do has to have a racial ethnic disparity lens. So definitely that would be something we would be looking at. The thing that I'm grappling with is, yes, we can do a quality improvement project. And for the first time, we have the largest neonatal project that's been done with the temperature control. So we're getting quite a few people, babies that are part of that study. But to really make sure every baby is screened, we thought about going back to the law and having it changed. But with the climate about newborn screening right now, we are scared to open that law again. And what would happen with it at this time? That was one of the things. I totally agree. That would be the best thing, one of the best things to do. But that was the concern.
So just in the interest of time, other questions that we've received. One of them would be, and this is, I think, mostly for Alex and Heather. And you, I think, alluded to a little bit in your thing, but I'll give you a little more time on it. If there was one thing that you wish someone had told you as you went home with your baby with congenital heart disease, what would it be? It's like a game show. I apologize. You guys have to unmute. Yeah.
Okay.
Go ahead, Heather.
Sorry, the question was one thing that going home.
Yeah. What if there was one thing you wish someone had told you as you went home with a baby with congenital heart disease? What would it be? You can think about that longer. Alex, do you have an answer on there?
And I'm not sure either. I think maybe a little bit more reassurance that he was likely going to be okay. Because I think we went home and, we were just scared of everything. We checked him. If he napped for too long, we were checking to make sure he was still breathing. And you leave the hospital so used to having him hooked up to monitors to where you don't have to worry about his oxygen, his pulse, his blood pressure, all those things, because the monitor will let you know. And it is actually very jarring when those are removed and you go to the step down unit and you go home with nothing. And so I think there's just a lot of insecurity, at least for as a parent, about SIDS is a real concern too, right? So you have so many concerns for a heart healthy baby on top of everything that comes with having a heart child. I think maybe just overstating like your child is okay now. And I know no one can guarantee that, but I think just giving the parents a little bit more confidence in that regard.
Over 10 years ago, we started something called the National Pediatric Cardiology Quality Improvement Collaborative. And that collaborative, it was initially focused on babies with hypoplastic left heart syndrome, but it's expanded to other conditions. And it looked at a standardized discharge, what you needed to tell families, how the baby should go home. It had standardized checklist for what the mother should do or the family should do if they saw there were red flags for contacting the providers. And they lowered the mortality in the end stage between the first surgery and second surgery for hypoplastic left heart syndrome. Parents have gotten involved with this. Mended Little Hearts is involved with this. There's another mother's group, and I always forget their names. The mother would kill me too. But I've gotten in trouble with it.
They've changed the name. It's Conquering CHD. That's why we get confused. It was
Okay.
PC something, but now it's Conquering CHD.
They also have come up with the list of questions that parents need to have answered before taking their babies home. So you don't have to recreate that. A lot of that's been created for you.
Heather, did you have anything to add on that?
Really, just more education. I think I didn't have that upfront hospitalization. And so I went home thinking that I otherwise had a very healthy baby. And so I think education about, so Coral was born in December, and we know, I know now, you know, our RSV season runs from October through when we stopped seeing it in our community in April, you know, or as late as April. And so really, I think just a lot more education for me, and understanding the importance of limiting family visits, you know, to kind of keep that bubble a little tighter. That's what I would say I wish I knew.
So another question. Thank you guys for opening up on that. Another question is, and I'm just reading this word for word. I have always wondered. Most critical heart disease causing death is ductal dependent and due to left-sided obstructive lesions. CCHD screening would pick up only cyanotic lesions. Could you discuss this, please? That may be Dr. Martin, Dr. Barbanel.
So I tried to do it in a phrase or two in the text, but they ductal dependent. There are two types of ductal dependent heart disease. There are the ductal dependent right heart, which you're correct, are traditionally the cyanotic lesions, blue babies. There are also the ductal dependent left heart diseases, and that will also result in a lower oxygen saturation. Not as low as what occurs with the blue babies, so-called blue babies, but it involves both. And then also, you know, CCHD screening picks up the kids with complete mixing, where there's one ventricular chamber that receives both the blue blood and the pink blood that all goes out to one vessel. So it picks up more than just the blue babies, and that's why that list has expanded, as noted in the Oster lessons learned.
So I think it's our final question we have time for, and I really appreciate everyone being willing to participate, and also to be willing to be kind of in the firing line of questions here. And this one is probably more for Heather. Sorry, I don't want to surprise you. And you know, Coral, I think Coral is 19 years old, you said, or she may be older now than when this was written. But do you have difficulty finding, or are you having difficulty finding adult transition, and have topics about reproduction come up at all? And if you prefer not to discuss, that's fine. These are questions that have been asked here.
Yeah, no. So no real difficulty transitioning into the adult kind of side of things. What I will say is I don't think we were quite mentally prepared. We were really handheld by our pediatric cardiologist up until we got a retirement letter in the mail. It's something that we had talked about and we were anticipating, but again, Coral is on a once a year follow-up. And so we saw our cardiologist in the beginning of the year and hadn't really thought too much more about it. But when we got the retirement letter at the end of the year, it was like, oh, this is a big deal. So now we need to find an adult congenital provider. Interestingly, you know, and I think this is probably how it is in medicine for most, is you pick where you want your patients to go to. So we were given a referral to a male adult congenital cardiologist, but you just mentioned reproduction. I have a daughter. I want my daughter to feel confident and comfortable that she can talk about family planning with her adult congenital provider, and I just didn't feel that would be something she would do with a male provider. So I sought out a female adult congenital provider, which fortunately for us, we have a couple in our community. And interestingly, our first appointment, while not quite being coddled, I realized that I hadn't thought about some things in terms of Coral's next intervention. She's due for intervention, but I hadn't thought about it in the way of family planning and reproduction. And so they offered two kind of paths. And it was something that I just kind of thought, when Coral gets to be about 18, 19 years of age, we're going to need to replace her conduit. And what was proposed was, why don't we do a melody valve and buy us a few years until she does start to plan a family. And then right before that, we do her conduit and we'll get her through pregnancy. Those are all things that we had never talked about. And I was actually really taken back and grateful at the same time that I got to experience that with her. But really for me, I find that if we could have started that process a little sooner, instead of wait until she's 18 and get a retirement letter in the mail, and that transition just sooner, maybe start talking about it around 16, maybe even sooner. I'm not too sure what the right answer is, but I think it would have been less of a shock for Coral and I. And I say that because I was 18 when I met our cardiologist. So I was 18 and he cared for Coral for 18 years. So I was a baby too. We were going through this together. So it was a shock for both of us, I will say.
So we are out of time. I want to just voice incredible appreciation and frankly admiration for how eloquent all of you are. This is this has been a true honor to have the opportunity to moderate this session. For those of you who asked a couple of later questions here, we will try to send those to our panelists here and have them answer those for you later on. And next slide, please. Just have to go through a couple of things here. We are working in the Texas Collaborative for Healthy Mothers and Babies on an upcoming project regarding this, and we're actually we'll at some point, once we get this to a point where we've approved going forward with it, we will be looking for people, and I think many of you on this panel would be tremendous people to be part of our project work group for this. And we hope that you'll consider participating if and when we get to that point sometime, hopefully later this year. A reminder on attendance and evaluation. I need to put my readers on now. Duration of attendance will be tracked to ensure attendees receive the current number of continuing education credits. You will get a personalized survey link for evaluation of the summit at the end of the summit. And to receive continuing education credits, you must complete the evaluation survey by next Friday, the 25th at 11:59 p.m. Eastern. I think that's next Friday. Next slide. A reminder to save the date. We hope you really enjoyed our sessions and the whole summit. Save the date for the 2023 summit, February 15th through 17th, 2023. So thank you all. I think that's our final slide. Thank you for joining us. We appreciate you. We hope you all have a wonderful weekend. Stay safe, and thank you for joining us.